Hello, my name is Claire Harrison. I'm a haematologist from Guy's and St Thomas's Hospital in London. Today, I want to speak to you about what's new from COMFORT-II. The COMFORT-II study is a randomized open-label multi-center phase 3 study where patients with myelofibrosis were randomized between ruxolitinib and best available therapy. This study formed one of a pair of phase 3 studies leading to the approval of ruxolitinib for the treatment of myelofibrosis. Primary endpoint of the study was spleen volume reduction, and secondary endpoints included symptom control and durability of response. What I want to share with you today is the 5-year analysis from this study. This study was conducted in 56 sites across 9 countries in Europe, as shown on this slide, and thus truly represents a pan-European selection of patients with myelofibrosis. Here you can see the durability of spleen response at the 5-year follow-up point from the study. Loss of response here is a spleen volume that is no longer a more than 35% reduction from baseline, but that is also a 25% increase over nadir. A rather complicated description, but the most important facet is shown on the graph. And here you can see that although the median duration of response to ruxolitinib in these patients was 3.2 years, there's a rather interesting plateau in response from beyond that time. So you can see the probability of maintaining response at 3 years is 0.51, but at 5 years has only dropped to 0.48. Let's have a look at some other data. So ruxolitinib is a JAK1 and 2 inhibitor. What does it do to the JAK2 V617F allele burden? Here is the data for the best absolute change from baseline in the JAK2 V617F allele burden for patients randomized to receive ruxolitinib in this study. And you can see here a spectrum of responses, with most patients having some quite modest reductions in allele burden, a few patients having an increase, and some patients having some more significant reduction. The summary, however, would be that the majority of patients had a reduction in allele burden over the course of ruxolitinib treatment. What I haven't shown you on this slide, but we have presented from this study, is that we also have some similar data for patients who have the calreticulin exon 9 mutations. Let's have a look at what's happening in the bone marrow for the patients on the COMFORT-II study. So this is a shift table showing what happened to fibrosis grade by treatment, showing baseline fibrosis across the top, with the last available post-baseline fibrosis assessment. There's a traffic light system operating here. Patients whose boxes are coloured green had an improvement in fibrosis grade. So, for example, you can see one patient went from grade 3 fibrosis, the highest grade, to grade 0. Patients with yellow-coloured boxes had stability of fibrosis grade, and those in red had some worsening. You can see a mixed pattern of responses, but overall about 16% of patients had improved fibrosis, including 4 who went to grade 0. So a balanced pattern here. Not something we would normally look at when we're treating patients, but an important biological effect of therapy. Here is the overall survival analysis for patients on the COMFORT-II study. You can see the median overall survival for patients treated with ruxolitinib was not reached, whereas for those in the control arm, either by intent-to-treat analysis, 4.1 years, or using statistical modelling counteracting the crossover effect, RPSFT, rank-preserving structural failure time analysis, was 2.7 years. What about adverse events for patients? Well, with 5 years follow-up, we see no change in the adverse event profile for patients treated with ruxolitinib. Some increase in bleeding events, the now well-described increase in infections, particularly herpes zoster, and a small, perhaps, increase in non-melanoma skin cancers, although, of course, this has been shown more significantly in patients with polycythemia vera receiving this drug. In conclusion, we've shared today the 5-year findings from the COMFORT-II study, showing the immediate benefits of ruxolitinib treatment, in particular spleen size, were maintained with long-term therapy. We also reviewed data with regard to JAK2 allele burden and bone marrow fibrosis. Hearing that long-term safety and tolerability are consistent with previous findings and no new adverse signals seen. Patients randomized to ruxolitinib had an overall survival benefit. This hypothetical benefit is now being taken forward in a subsequent study assessing the benefit of ruxolitinib treatment earlier in myelofibrosis. Thank you for listening to this presentation today.